Indomethacin in gout and pain management, pharmacology and clinical use. Gout affects approximately 4% of adults in the United States, with rising prevalence linked to metabolic syndrome and aging. Indomethacin, a potent nonsteroidal anti-inflammatory drug, NSAID, inhibits cyclooxygenase 1 and 2, reducing prostaglandin synthesis and inflammation in acute gout flares. Diagnosis relies on synovial fluid analysis showing monosodium urate crystals under polarized light microscopy, with serum uric acid greater than 6.8 mg per deciliter supporting the diagnosis. First-line pharmacologic management includes indomethacin 50 mg orally 3 times daily for 3 to 7 days, with tapering based on symptom resolution, per American College of Rheumatology, ACR, 2020 guidelines. Key points. Note: indomethacin is dosed at 50 mg orally every 8 hours for acute gout, with maximum duration of 7 to 10 days to minimize gastrointestinal (GI) toxicity. The American College of Rheumatology, ACR, 2020 guidelines recommend indomethacin as a first-line NSAID for acute gout when no contraindications exist. Serum uric acid levels greater than 6.8 mg per deciliter, 404 mol/L, define hyperuricemia, the biochemical basis of gout, due to supersaturation of monosodium urate in extracellular fluid. Indomethacin reduces pain scores by 50% within 24 hours in 78% of patients with acute gout, based on randomized controlled trials. GI bleeding risk with indomethacin is 2.7-fold higher than placebo, NNH equals 120 over 6 months, necessitating proton pump inhibitor, PPI, co-therapy in high-risk patients. Indomethacin is contraindicated in patients with estimated glomerular filtration rate, eGFR, less than 30 ml/min/1.73 m superscript 2 due to risk of acute kidney injury, AKI. In elderly patients, greater than 65 years, indomethacin dose should be reduced to 25 mg every 8 hours due to increased risk of confusion, falls, and renal impairment. Indomethacin crosses the placenta and is classified as FDA Pregnancy Category C. Use in pregnancy is limited to short-term, low-dose regimens only if benefits outweigh risks. The Beers Criteria 2023 list indomethacin as potentially inappropriate in older adults due to high risk of CNS side effects, incidence 15 to 20%, and nephrotoxicity. Indomethacin should be avoided in patients with aspirin-exacerbated respiratory disease, AERD, which occurs in 7% of adult asthmatics and carries a 30% risk of severe bronchospasm with NSAID use. For pediatric gout, rare, indomethacin may be used at 1 to 2 mg/kg/day divided every 8 hours, not exceeding 150 mg per day. Indomethacin-induced hepatotoxicity occurs in 0.2% of users, typically within 1 to 3 months, with alanine aminotransferase, ALT, elevations 3 times upper limit of normal, ULN, requiring discontinuation. Overview and epidemiology. Gout, defined by the International Classification of Diseases, 10th revision, ICD-10, as M10, is a chronic inflammatory arthritis caused by deposition of monosodium urate, MSU, crystals in joints and soft tissues. It is the most common inflammatory arthritis in men over 40 years and affects approximately 4% of the U.S. adult population, equating to over 10 million individuals. Globally, prevalence ranges from 1% in low-income countries to 6.8% in New Zealand Maori populations, with a rising trend attributed to aging, obesity, and metabolic syndrome. In Europe, gout prevalence is 1.4% in women and 3.4% in men, based on 2022 European Alliance of Associations for Rheumatology, EULAR, data. The condition disproportionately affects males, with a male-to-female ratio of 3.5 to 1, though postmenopausal women approach male incidence rates due to declining estrogen-mediated uricosuria. The median age of onset is 52 years in men and 63 years in women. Racial disparities exist. African Americans have a 1.8-fold higher risk of gout compared to non-Hispanic whites, independent of socioeconomic status, likely due to higher rates of hypertension and chronic kidney disease, CKD. The economic burden is substantial, with annual U.S. healthcare costs exceeding $9.7 billion, including $3.5 billion in direct medical costs and $6.2 billion in indirect costs from work disability and absenteeism. Pathophysiology. Gout arises from chronic hyperuricemia, defined as serum uric acid levels exceeding 6.8 mg per deciliter, 404 mol/L, the solubility threshold for monosodium urate, MSU, in physiological conditions. Uric acid is the end product of purine metabolism, primarily derived from endogenous nucleic acid turnover, 85%, and dietary purines, 15%. Xanthine oxidase catalyzes the conversion of hypoxanthine to xanthine and xanthine to uric acid in the liver. Renal excretion accounts for 70% of uric acid clearance, with the remainder eliminated via the gastrointestinal tract. Hyperuricemia results from either overproduction, 10% of cases, or underexcretion, 90%, of uric acid. Overproducers include patients with enzyme defects such as hypoxanthine guanine phosphorybosyltransferase, HGPRT, deficiency, Lesch-Nyhan syndrome, which increases purine salvage and de novo synthesis. Underexcretion is commonly associated with polymorphisms in renal urate transporters, SLC22A12, URAT1, which reabsorbs urate in the proximal tubule, and ABCG2, which secretes urate into the gut and urine. Loss of function mutations in ABCG2, Q141K variant, reduce urate excretion by 25 to 30% and are present in 30% of gout patients. Clinical presentation. Acute gout typically presents as a sudden, severe monoarticular arthritis, most commonly affecting the first metatarsophalangeal joint, podagra, in 85% of initial flares. Onset is often nocturnal, with 70% of patients reporting awakening with excruciating pain. The affected joint becomes erythematous, swollen, warm, and exquisitely tender, with pain scores averaging 8.5/10 on the visual analog scale, VAS. Fever may occur in 30% of cases, with temperatures reaching 38.5 degrees Celsius (101.3 degrees Fahrenheit). Other commonly involved joints include the midfoot, 15%, ankle, 10%, knee, 8%, and wrist, 5%. Polyarticular involvement occurs in 10% of initial flares but increases to 30% in chronic tophaceous gout. Untreated, an acute flare lasts 5 to 14 days, with median duration of 7 days. Diagnosis. Diagnosis of gout requires a stepwise approach integrating clinical suspicion, laboratory testing, and imaging. The gold standard is identification of negatively birefringent, needle-shaped monosodium urate, MSU, crystals in synovial fluid or tophus aspirate using compensated polarized light microscopy. Sensitivity is 85% and specificity 100% when performed by an experienced microscopist. The 2020 American College of Rheumatology, ACR/European Alliance of Associations for Rheumatology, ULR, classification criteria assign points across domains: clinical, 6 to 10 points, laboratory, 3 to 6 points, and imaging, 4 to 8 points. A total score greater than or equal to 8 confirms gout with 92% sensitivity and 89% specificity. Clinical criteria include key points, more than one attack, 2 points. Maximum inflammation at less than 24 hours, 2 points. Podagra, 2 points. Monoarticular arthritis, 2 points. Management and treatment. Acute gout management focuses on rapid pain relief and inflammation control. Patients should rest the affected joint, apply ice packs for 20 minutes every 2 hours, and elevate the limb. Monitoring includes vital signs every 4 hours initially, especially in elderly or comorbid patients. Hydration should be maintained with oral fluids, greater than or equal to 2 L/day, unless contraindicated by heart failure or CKD. Immediate interventions include pharmacologic therapy within 24 hours of flare onset. Delay beyond 48 hours increases median flare duration from 7 to 12 days. Key points: dose, 50 mg orally every 8 hours for 3 days, then 25 mg every 8 hours for 4 to 7 days. Maximum duration, 7 to 10 days. Route, oral, also available as suppository 50 mg every 8 hours if oral intake impaired. Mechanism, non-selective COX-1 and COX-2 inhibition, reducing prostaglandin synthesis. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.